My voice is clear? Okay. All
It's
right.
my internet there.
Cheryl ma'am, should we wait? Meanwhile, good evening, everyone. This is Dr. Mansi Vora, and on behalf of the IPS West Zone Women's Psychological Health Subcommittee, I welcome you to this engaging talk on psychoendocrinology. So, of course, a lot of us have experienced this that we see some patients and we hit a roadblock sometimes, and there are some other medical features. And a lot of times, it is because of endocrinological problems. I have encountered this in 9 years of my private practice, and also sometimes a lot of endocrinologists have referred patients to me. And so we felt, as a women's psychological subcommittee, we felt that the importance of endocrine parameters, the importance of hormones is significant. And if we could have something to enlighten us on that, it would be great. So, with that in our mind, we thought of having this session. And I would like to introduce our chair for today, Dr. Cheryl John. Dr. Cheryl, are you here? Yeah. So, Dr. Cheryl, as we all know, is an extremely well spoken person. She is globally seen in various Asian and also international conferences, as well as national conferences, giving various talks. She's a consultant psychiatrist here in Mumbai, a very, very well known name, and very popular for her saris as well, and extremely academically oriented. Every time we hear her talk, we always end up learning a lot more than what we know. So, we welcome you, Dr. Cheryl, as a chair of this session. And may I now ask Dr. Cheryl to introduce the speaker for the day? Yogendra, can you please share the slide?
Yes.
Am I audible now?
Yes, you are very well.
Good evening, everyone. I'm very happy to be part of this unique program. And right at the beginning, I would like to thank the Indian Psychiatric Society, especially the Western Zonal Branch, and the President, Dr. Neena Sawant, and of course, our dear Mansi Vora, for giving me this opportunity to participate in this program. And I also extend a warm welcome to our esteemed speaker, Dr. Bharat Sharma. This is going to be a very unique program because it's very rare that we psychiatrists allow somebody else to speak. So I think we need a mental break, and that's why we thought that we would have another, very erudite speaker to enlighten us on a important topic. Now, to introduce a topic also, right, over the last few years, an understanding of psychiatry has changed. We look at the aspects of how inflammation, how your hyperactive autonomic nervous system, all these contribute to various dimensions and symptom profile in our patients with psychiatric illnesses, even the presentations, right? And as endocrinologists, we're also looking at a similar pattern in the diseases that they treat. So when Dr. Sharma is going to share his pearls of wisdom, it will help us to enhance our knowledge as well as our clinical acumen, which is going to translate into better patient care. Our collaboration with our endocrinologist colleagues is not just because we have a similar symptom profile or a similar pathogenesis of diseases, but also because a lot of our patients with chronic illnesses seen by the endocrinologist have comorbid psychiatric disorders, and our patients with psychiatric disorders on medications develop a number of disorders, including lifestyle issues like obesity or diabetes. And that is why our speaker, Dr. Bharat Sharma, here is here to enlighten us. And it gives me immense pleasure to introduce him. So Dr. Bharat Sharma has completed his MBBS and MD from Gujarat, but he's also a Mumbaikar because he did his DM endocrinology from TNMC Mumbai, and he's a gold medalist at his exam. This is one of the few awards, or one of the many awards that he has won during his career. He's presently practicing at Sharma Diabetes Clinic, which is at Nanpura at Surat. he has many awards, like I told you, a lot of various publications to his credit. And I'm sure, I think I was just going through his CV and I realized that he's very, very keenly interested in having a lot of collaborative work, because he's given a number of talks in not only in his endocrinological forums, but also to the Association of Physicians, to the Gynec Association in Surat. So we are really very happy to have you, Dr. Bharat Sharma, and looking forward to your presentation. So handing it over to you.
I would quickly like to add something before Dr. Sharma begins. That because of some commitments, he would be leaving after half an hour. So if anyone has any questions, they're welcome to put them in the chat box so he can address it while he's still here with us. And post that, we can have experience sharing sort of a session with all our esteemed colleagues over here. Thank you. Over to you, Dr. Sharma.
Good evening, all the doctors who have joined in, and I would like to begin by thanking Dr. Mansi Vora and the entire association, Psychiatric Association, who have invited me for this discussion. I understand that endocrine perspective of psychiatric issues, or the other way around, is required nowadays, when a lot of our endocrine patients also come up with symptoms of psychiatric issues. Or one thing that I often discuss with my doctor colleagues, or even some of my friends, is that it is very difficult to please a diabetic patient, because even if the blood sugars are well controlled, they are in some sort of anxiety or depression regarding the condition itself, or regarding the treatment that they are being prescribed. Patients who are on pills want to stop the pills. Patients who are on insulin want to go off insulin and start oral treatment. So there is some amount of denial even in young diabetic patients when they are newly diagnosed. Not just young diabetic patients, but even doctors who are diagnosed with diabetes. There is always a lag period of maybe 6 months to even a year before they actually start treatment. So there is always a degree of denial when a lifelong condition is diagnosed for anybody, whether it be a patient or a doctor. Apart from that, obviously there are issues with other endocrine disorders, psychotic issues in patients with thyroidism, hyperthyroidism, and almost all endocrine disorders are associated with some sort of psychiatric manifestations. So without any further ado, I would now share my screen and uh, discuss the presentation with you. Just a minute. All right. So I hope that the presentation is visible. I'll make it full screen in a while.
Yeah, it's visible.
All right. So hopefully it is visible in the full screen mode now.
It is better, yeah.
All right, fine. So as discussed earlier, we'll be talking about the psychiatric manifestations of endocrine disorders. So as I said, endocrine system has been studied quite extensively from molecular, biochemical, and physiological approaches. So whenever it comes to endocrinology, it is usually about blood testing, about hormonal evaluation, about regular monitoring of hormone levels, and also about clinical features of patients. The psychiatric problems that these patients face are often either ignored or not delved into in as much detail as the patient would want to. And even when we ask our patients to meet psychiatrists for their psychiatric issues, for depression, for anxiety, uh, I don't know why there is this taboo regarding management of psychiatric issues in all kinds of patients, but they take 6 months to 12 months before they actually consult a psychiatrist. I'm sure you must be having experience of these kind of delays in taking treatment from psychiatrists. We know in detail about the clinical and biochemical manifestations of endocrine disorders. Um, Although I'll be discussing a few of those during my case presentations or during the endocrine cases that we'll be discussing in a short while. The psychiatric comorbidities in endocrine disorders, as I said, are ignored or become apparent only when quite advanced in their presentation. and we'll discuss mainly the psychiatric manifestations today of some common endocrine disorders. So we'll begin with Cushing's syndrome or hypercortisolism. So, hypercortisolism is basically excess steroid levels in the body. It is known as Cushing's syndrome because it could be either exogenous or endogenous. Many a time, our patients are taking steroids for a number of reasons, like skin disorders, skin rash, over-the-counter steroids for bone pains, for respiratory issues, and these patients develop obesity, develop stria, bruises over their abdomen and over the joints. They develop difficulty in walking due to proximal myopathy. And apart from that, there is one common side effect of steroids, which is steroid induced psychosis. This is common, especially in ICU patients who receive very high doses of steroids. It is often required to restrain these patients in the ICUs and the hospital wards, where when they are given very high doses of IV steroids, they behave erratically, they thrash around in their beds, and as soon as the steroids are stopped, that psychotic component of the condition is gradually resolved. But at the same time, chronic low dose steroid therapy can also result in depression, anxiety, even mania or hypomania, according to the dosage that has been prescribed. And the major issue with these patients who have been on chronic steroid therapy is that they tend to gain a lot of weight. And once the high dose steroid therapy is stopped, the HPA axis takes a long time to recover. So the HPA axis is the hypothalamo pituitary adrenal axis. Whenever a patient receives high doses of steroids extraneously, the axis gets suppressed. And that's why the endogenous production of steroid goes down significantly. So these patients, although having symptoms of steroid excess, actually have steroid deficiency once those extraneous steroids are stopped. And these patients are extremely likely to land up in a crisis, a hypocortisolemic crisis, if they develop any acute infection. So, because of all these symptoms, because of occasional cataracts or glaucoma due to steroids, these patients develop depression, anxiety, and panic disorders. Some of these symptoms resolve after the treatment of hypercortisolism. At the same time, there can be endogenous Cushing's syndrome, where the body actually produces excess amount of steroids either due to a tumor in the pituitary gland or a tumor in the adrenal gland. So these patients, when they come to us, manifest in a similar manner, where there is obesity, stria, bruisability, proximal myopathy, and they have some amount of anxiety. What has been interestingly noticed is that as soon as we treat these patients for their condition and the tumor is removed, they develop low cortisol levels, and this in turn causes them to go into a state of depression again. So low cortisol levels after prolonged exposure to high steroid levels in the body can also trigger depression, low mood, and so on. So this is regarding psychiatric effects of Cushing's disease. Uh, that brings us to the second part, which is Addison's disease or hypocortisolism. Addison's disease is basically poor production of steroids from the adrenal glands due to autoimmune destruction of the adrenal gland. Just like we have a large number of patients of hypothyroidism where there is autoimmune destruction of the thyroid gland, similarly, there is a condition known as Addison's disease where there will be autoimmune destruction of both the adrenal glands. These patients will be lean and thin, unlike the hypercortisolemic patients. They will have anorexia, nausea, vomiting. They will have generalized pigmentation of their body. And because of chronic weight loss and anorexia, these patients will also develop some sort of depression and low mood and other symptoms of a similar nature. Another common problem in patients with hypocortisolism or Addison's disease is that they can land up with severe hyponatremia, low serum sodium. And hyponatremia can manifest itself in the form of a psychiatric illness when actually it is a neurological problem where the patient will again develop either delirium, altered sensorium, may lapse into a state of coma, irritability, irrelevant talking. So these are all manifestations of hyponatremia. It might be wrongly diagnosed as a psychiatric condition or a psychosis or schizophrenia when actually it is an electrolyte abnormality which needs to be corrected. I have seen similar patients of hyponatremia where the problem is not in the adrenals but in the pituitary gland. Patients with Sheehan syndrome, where there is destruction of the pituitary gland after a postpartum hemorrhage, which is very rare these days. But still, I have several patients following up with me who have been having Sheehan syndrome or empty sella or absent pituitary gland for years together, and the diagnosis has been missed. Patients have been chronically treated as having depression or low mood, and actually they have a condition known as panhypopituitarism, that is low pituitary hormones, both thyroid, adrenal, steroid, and every other hormone is suppressed in those patients. And again, they come with hyponatremia. As soon as the underlying condition is treated, the so-called psychiatric manifestations of this problem also resolve completely. Um, we'll next discuss diabetes mellitus, which is, as I said earlier, probably the most common association, which has probably the most common association with psychiatric problems. Um, I I have observed in most of my patients that it is very difficult to please a diabetic patient, even with good glycemic control. Patients often have this sense of failure or this sense of having a chronic long-term disease whereby they cannot eat what they want to, they cannot have a routine physical activity, which uh, in our country is the sedentary lifestyle. So people are not habituated to a daily routine of physical activity. So as soon as they stop exercising, stop following their diet plan, they end up with hyperglycemia. So hyperglycemia in itself is a psychological condition, because whenever a patient develops hyperglycemia and it does not get resolved with oral anti-diabetic agents or insulin, they then tend to fall into a vicious circle whereby they tend to give up on their diabetes, on their management of diabetes, and that's why they stop exercising, stop taking their medications, stop taking their injections. So hyperglycemia worsens. This can in turn lead to microvascular and macrovascular complications. So most of the diabetic patients that we come across have some sort of uh, problem from the psychiatric point of view. Um, Trials have shown that about 1 out of 4 diabetic patients have clinically significant depression, and there is a lot of binge eating in type 2 diabetes mellitus patients. It has been said that whatever is refused to a person is the most likely thing that he or she will go after. So whenever we advise our diabetic patients to stay away from sweets or desserts or high calorie food, that's the thing they crave the most. And so binge eating is seen in about 12% of type 2 diabetes mellitus patients. On the other hand, I'm sure you must have come across a lot of teenagers who are suffering from type 1 diabetes mellitus, and they have different issues. Some of them have anorexia nervosa or bulimia nervosa, whereby they uh, avoid carb intake to remain thin. Insulin is a trophic hormone, so insulin will cause weight gain. So some of these patients, in order to remain thin, to not gain weight, either don't take their insulin, reduce their carbohydrate intake significantly. Also, type 1 diabetes mellitus is a much more difficult condition to manage as compared to type 2 diabetes mellitus. Many of these patients have been diabetic for years together, starting from their early childhood years. They have been taking 3 to 4 injections daily for years together. So there is always a sense of depression, sense of failure amongst these patients when the glycemic control is not that good. They see their siblings, their peers enjoying a healthy life, not taking regular injections, not being restricted in their calorie intake. And there is always comparison between children. Even the most adjusted children of with type 1 diabetes mellitus will have some kind of issues. We have seen several patients who manipulate their blood sugar readings because they are more afraid of the doctor and what he or she will say when they see high blood glucose values rather than the condition itself. So that is another problem where we see manipulation of blood sugar readings, and then these patients end up with diabetic ketoacidosis because they have not been monitoring their blood sugars regularly. Patients with end-stage diabetic complications may also suffer from severe depression and suicidal tendencies. There are a lot of comorbidities seen in diabetic patients where chronic kidney disease, ischemic heart disease, severe stroke can occur in our diabetic patients. There are patients with diabetic foot who develop ulcers in their feet, and this results in amputations, significant deterioration of quality of life. These patients will often be dependent upon others for their routine care, and this could in turn result in a lot of psychiatric problems. Newly diagnosed diabetic patients, as I said earlier, uh, may have fear of hypoglycemia and a sense of denial for the disease. Uh, it is very difficult at times to convince certain patients regarding the need for starting therapy. Many diabetic patients go untreated. Today itself, I saw 2 to 3 diabetic patients who had been diagnosed with diabetes about a year back, but have not yet started treatment because of this prevalent myth in the society that once you start treatment for diabetes, you cannot stop it. That is obviously the case because diabetes is a long-term condition. There is hardly any cure for it. Uh, Nowadays, there are studies which show that significant weight loss would help in causing remission of diabetes, but most patients need to be on therapy for life. So we need to address this initial after the diagnosis of diabetes because there are several trials which show that when a patient is newly diagnosed with diabetes, if you keep the HbA1c below 6.5 in the first year after diagnosis, you are much less likely to end up with complications 10 years or 15 years down the line. And patients who do not manage their blood sugars well in the first few years after diagnosis, no matter what they do later on in life, 10 years, 15 years down the line, the damage has already been done, and so these patients are more likely to develop microvascular and macrovascular complications. So this initial fear of hypoglycemia, fear of needles, uh, reluctance to start oral antidiabetic therapy, denial for the disease, this needs to be managed aggressively by proper counseling of diabetic patients. Coming to thyroid and thyroid related psychiatric manifestations or symptoms. So hyperthyroidism is a condition where there is excess thyroid hormone production, and uh, I tell most of my thyroid patients, especially patients who are suffering from hypothyroidism, that it is a very innocuous condition. It is not a major disease as long as they continue to take that tablet regularly. uh, so hyperthyroidism is also easily manageable if the patient regularly consults their doctor and takes their necessary dosage of the medication. But hyperthyroidism can often masquerade as mania or anxiety because of the increased metabolic rate. Hyperthyroidism will result in increased sympathetic activity, and that will in turn cause palpitations, tremors, sweating, insomnia, restlessness, fatigue, a dazed look due to thyroid eye disease. And I'm sure all of you must be having patients with psychosis or schizophrenia who have all of these symptoms, which can also be seen just in hyperthyroidism, where the patient does not have any underlying psychological condition. In fact, I have seen several patients who are admitted with psychiatric issues who actually turn out to have hyperthyroidism. I have seen patients who have been admitted for arrhythmias or cardiac disorders who actually have thyroid conditions. So it is essential to screen for thyroid problems when you come across patients with these kind of symptoms. So as I said, these symptoms may be wrongly attributed to psychiatric conditions like mania or anxiety, and use of beta blockers to reduce the increase. I'm sorry about that. So use of beta blockers to reduce the increased sympathetic drive and correction of the underlying hyperthyroid state brings about a complete reversal of the symptoms. So hyperthyroidism, as I said, is an easily manageable condition if the diagnosis is made promptly and the treatment is given appropriately. Then hypothyroidism is a common problem, especially in females. It is an autoimmune condition, and just like hyperthyroidism can masquerade as mania or anxiety, similarly, hypothyroidism can masquerade as depression. In fact, depression is one of the most common symptoms of hypothyroidism. Patients will be dull, having dry skin, pasty pale facial appearance, low mood, poor involvement with surroundings, slow slurred speech, decreased activity levels. Mind you, these all symptoms are seen in overt hypothyroid patients, where the TSH is often above 100, above 150. I have seen patients where the TSH level is above 500 microinternational unit per ml. So these are patients with overt hypothyroidism where there is complete destruction of the thyroid gland or complete absence of the thyroid gland. So in these patients, because of low metabolic activity, cognitive dysfunction, and overall low metabolic rate, uh, depression is a common symptom. Many of these patients are often diagnosed late. In fact, children with hypothyroidism often get diagnosed 3 to 4 years after the actual onset of the disease. And so that is a missed opportunity because as soon as you start thyroxine, obviously all of these symptoms will go away. But children who are still growing, if the treatment and diagnosis are delayed, then the patient ends up with short stature because of retardation of epiphyseal growth plate proliferation. So patients with severe hypothyroidism may also develop a myxedema coma-like state. So myxedema coma is the extreme form of hypothyroidism, which usually is triggered by an infection or dehydration or fever or myocardial infarction or CV stroke in a patient who has underlying severe untreated hypothyroidism. So these patients will have cold clammy extremities, bradycardia, and so on and so forth. I will not discuss that in this forum, but uh, to make a long story short, hypothyroidism is commonly associated with depression. Patients with subclinical hypothyroidism. What is subclinical? We have already discussed overt hypothyroidism. Overt is where the TSH is quite high, T3 and T4 are quite low. On the other hand, we have many patients with subclinical hypothyroidism. In this era of full body checkups and a multitude of tests done annually by many patients, we often come across patients where the TSH level is marginally elevated between 5 to 10 or just above 10. And these patients have more symptoms than some of our overt hypothyroidism patients, where the TSH is more than 100, the patient is absolutely quiet, not troubling anybody. And these patients with TSH between 5 to 10 come to the OPD with all sorts of symptoms: weight gain, scalp hair loss, depression, body pain, generalized body aches, and so on and so forth, which are not commensurate with the actual degree of hypothyroidism. So the problem with subclinical hypothyroidism is that it is quite common. Many of these patients will get resolution of the condition by itself without any thyroxine, but subclinical hypothyroidism can cause these kind of psychiatric symptoms, mainly depression and low mood. And treating subclinical hypothyroidism in some patients will obviously benefit them, but others might not have such severe subclinical hypothyroidism or might not have subclinical hypothyroidism at all. In those cases, you should just wait and recheck the TSH in about 6 to 8 weeks' time. Treatment of hypothyroidism usually results in significant improvement in patients where the initial TSH is more than 20. Patients with subclinical hypothyroidism, as I said, may or may not respond favorably to treatment with thyroxine from the psychological standpoint. Pheochromocytoma. So this is an adrenal tumor which produces epinephrine and norepinephrine. It causes significant elevation of blood pressure, weight loss, paroxysms of sweating, palpitation, headache. So only recently I had a patient with pheochromocytoma who had been admitted in a hospital for elevated blood pressure, and the patient had also been on treatment for anxiety and panic disorder for quite some time. So I was called in because the blood pressure was not getting controlled, and when we evaluated the patient, he turned out to have about 8 by 6 centimeter lesion in his adrenal gland, which was secreting epinephrine and norepinephrine. So this patient had a pheochromocytoma. Apart from that, obviously he had hypertension, diabetes, and anxiety. So pheochromocytoma is actually considered the great masquerader. It can present in any way, but treatment of pheochromocytoma often resolves all the issues. If it has been treated promptly, the blood pressure goes away, the blood sugar levels get well controlled, and the panic attacks and the anxiety that the patient is suffering because of high epinephrine and norepinephrine levels will also go down significantly. Again, this is due to increased activity of the sympathetic nervous system. Hypercalcemia and hypocalcemia. So patients with hypercalcemia, severe hypercalcemia due to hyperparathyroidism, like patients who have an adenoma in the thyroid gland, can develop severe hypercalcemia. This will again result in anorexia, weight loss, nausea, recurrent bone pains, kidney stones, fractures. So the intractable bone pains that some patients have are often wrongly attributed to either depression or fibromyalgia or muscular disorders, which are all functional and not organic. And some of these patients actually have a condition known as hyperparathyroidism. So, doing a simple serum calcium level would diagnose the condition. And once you diagnose the condition, treatment is quite easy. Dissection of the tumor will not only control the hypercalcemia, but will also help the patient with the bone pains and the fractures and other problems. So I have in the last month itself evaluated 3 to 4 patients of hyperparathyroidism who have been who had hypercalcemia for 2 to 3 years, developed severe bone pains, but due to some reason or another, they either did not follow up with their doctor regularly, or the diagnosis of hyperparathyroidism was missed. And now all of those patients have undergone the surgery. They are much better. The calcium levels have come down. Obviously, when the diagnosis is delayed for a prolonged period, the treatment, even after treatment, the strengthening of the bones can take some time. That is known as a hungry bone syndrome. So patients who have been hyperparathyroid for several years may take several months to a year for the bones to regain their normal strength. So these patients have psychological symptoms or depression mainly because of bone pains and recurrent fractures. Similarly, hypocalcemia, either due to hypoparathyroidism or due to chronic kidney disease or due to parathyroid surgery or thyroid surgery, can be associated with basal ganglia calcification, leading to symptoms of involuntary movements, dysarthria, depression, carpopedal spasms. So hypocalcemia can also cause symptoms which are to an extent similar to any psychological condition. And when treatment is provided for hypocalcemia, many of these symptoms recover significantly. However, once basal ganglia calcification has set in, it is difficult to reverse it. So some of these patients will continue to have involuntary movements because of basal ganglia calcification. Andropause or low testosterone levels. Now, menopause is a commonly discussed and a commonly encountered condition in our routine clinical practice. People, not only doctors, but patients are also quite aware about menopausal transition, about menopausal hot flashes, about the changes that occur in a woman's body during menopause. But andropause is much less commonly diagnosed. In fact, it is much less common in general. Andropause usually occurs after the age of 65 or 70, and that too is not uniform. Not everybody develops andropause, not every male develops andropause, but andropause or low testosterone levels due to any pathology can be associated with depression and anxiety secondary to erectile dysfunction. Other symptoms can include low mood, sense of fatigue, failure, lethargy, muscle pains. Muscle pains are quite common in androgen deficiency, and many times when no other cause is discovered in patients with lethargy or muscle pains above a certain age, then asking for symptoms like erectile dysfunction or decrease in shaving frequency or decrease in libido can often help in diagnosing the condition. On the other end of the spectrum, we have androgen abuse in competitive sports, which, although illegal, is still quite commonly practiced, as many of you might have come across in your clinical practice. Uh, these drugs are used, androgens are used for performance enhancement, and this can lead to aggressive behavior, suicidal tendencies, rage, and an inclination towards committing crime. So menopausal transition is probably a more difficult stage in the life of a woman than even menarche. Starting menstruation or menarche around the teenage years is probably not as difficult for a girl to cope with as menopause. Um, Women are often told about their menses by their mothers, by their sisters, by other elderly women in their families, and so they are quite prepared for the menstrual transition. But menopause is still not as commonly discussed as we would want it to be, and so many patients will come with hot flashes, and they don't know what the reason for the hot flashes is. They will have mood changes, irritability, depressive symptoms. Um, they will have redistribution of fat, where the female fat distribution is known as the gynoid distribution. Usually the fat distribution is in the lower half of the body, while the male fat distribution is known as the android distribution, where the fat is deposited mainly in the visceral tissues or in the abdomen. So as soon as the woman develops the menopausal is around the menopausal age, she might have a redistribution of fat from the gynoid to the android form of fat distribution. And so there will be other metabolic disorders like hypertension, dyslipidemia, diabetes, which might accompany the menopausal transition. As I said, low mood, depression, lethargy, bone pains due to osteoporosis, abnormal facial hair growth, which is also quite common in the menopausal age because of the relative change in the androgens to estrogen ratio in a woman's blood, can result in significant psychological morbidity in menopausal women. So, uh, this is the last slide. What all things should be screened for when we are seeing a patient for any psychiatric issue? How do we test for endocrine disorders? So, thyroid function is quite easy. I mean, it is now quite commonly practiced by all specialties. You can do just a T3, T4, TSH and look at the entire profile in total to decide what the patient has. As I said earlier, subclinical hypothyroidism is often overdiagnosed and wrongly attributed to be the cause of all problems in many patients. Fasting prolactin level, this is also a test which has now apparently been included in the full body checkups. And the problem here is that most patients with psychiatric issues who are on psychotropic drugs or antidepressants or antipsychotics, all of them will have elevation of prolactin because most of these drugs work by either inhibiting the dopamine receptor or by uh, acting on the serotonin receptors or antihistaminics. Almost all drugs which come within the domain of a psychiatrist are associated with prolactin elevation. So what happens is that many of these patients have high prolactin, develop galacturia, and then the gynecologist or the treating physician advises an MRI of the pituitary straight away. So the the guidelines suggest that whenever there is elevation of prolactin, we have to first rule out any incriminating drugs. 90% of cases of hyperprolactinemia are actually drug induced. So stopping the drugs which are being taken, which can cause hyperprolactinemia for just 2 to 3 days can bring down the prolactin levels from above 200 to 15 to 20 nanogram per ml also. Then there is glycemia evaluation for most patients, which is required especially above the age of 45. Cortisol levels help in diagnosing Cushing's syndrome and Addison's disease. I will not go into the details of testing for Cushing's disease because it is a long discussion. There is an algorithm that needs to be followed. Serum calcium should be tested in patients where you find symptoms similar to hypercalcemia or hypocalcemia, which we have already discussed. Metanephrine should be tested in patients who have paroxysms of hypertension, headache, sweating, restlessness, anxiety, panic attacks. And obviously, FSH, LH, estradiol, and testosterone need to be tested in patients who are undergoing the menopausal transition or males who are having symptoms of androgen deficiency. So to conclude, endocrine disorders are often masked in patients with psychological symptoms. Patients often go undiagnosed for years or decades. Hypothyroid patients, Cushing's patients, patients with Sheehan syndrome often do not either meet a doctor or their diagnosis is missed for several years, resulting in delayed treatment and non-resolution of the psychological and other symptoms. So appropriate screening, testing, and proper treatment can ameliorate not only the endocrine condition, but also help with the psychological well-being of the patient. That finishes the discussion from my side. Thank you very much for listening in. I would now like to hand over the session to Dr. Mansi Bora and to Dr. Shelley for any further proceedings.
Uh, Thank you, Dr. Bharat. I would allow the other people to for the vote of thanks. But meanwhile, if you have 5 more minutes, are you open for any questions right now?
Yeah, sure, no problem.
Okay, so we have some interesting questions. First one being, how do you treat males with low desire, arousal, or with low testosterone, or the ones who have normal levels? Any inputs on that?
Right. So, as I said, androgen deficiency needs to be diagnosed first. So, there are type A symptoms and type B symptoms in androgen deficiency. Type A symptoms being hardcore symptoms of androgen deficiency like erectile dysfunction, low libido, low sexual drive, and B symptoms like lethargy, muscle pains, fatigue, and so on and so forth. So, whenever we screen for androgen deficiency, we check the total testosterone level early in the morning, and if it is found to be low, we also check FSH and LH to diagnose whether the problem is with the pituitary or in the testis. So if the total testosterone level is less than 270 nanograms per deciliter, we usually treat with testosterone injections. Once a month is the usual protocol. Some patients require the injections once every 15 days or once every 21 days. There are testosterone gels and patches also, gels available in our country, apart from the injections. But testosterone will only take care of the erectile dysfunction and the sexual drive. It will have no impact in patients with infertility. So testosterone should not be used where the concern of the patient is infertility. In such cases, if the problem is with the pituitary gland, then gonadotropin hormone therapy like FSH and LH is used to treat those patients. I hope that answers the question.
Yeah, that was great. The next one is, Does chronic homeopathic medication affect the cortisol axis? Do you have any idea about that?
Right. So to tell you the truth, I have no idea about homeopathic or Ayurvedic therapies. The only thing that I can tell you is that there are patients who have been on so-called Ayurvedic therapy and have developed steroid-related complications. I don't know what the contents of some of these Ayurvedic or homeopathic medications are. So I would not be the best person to answer that. But I have seen patients who have developed exogenous Cushing's due to chronic steroid therapy in the form of Ayurvedic medication.
Thank you. Thank you for letting us know that. The next one, any advice regarding Ozempic misuse in some clients?
Right. So the thing is, Ozempic is not yet available in our country.
Okay.
There are patients who procure it from the US, many from their relatives. So it is used mainly for treatment of diabetic patients, but it is also gaining approval for treating non-diabetic patients with obesity. So the problem is that although it is a good drug for treatment of obesity, you have to pick and choose your patients. It is not available freely in our country. In fact, it is not available at all in our country. In other countries where the government takes care of the insurance part, it is procured by many patients just for treating obesity. The only problem is that people no longer follow lifestyle modification and only take injectable therapy or oral therapy for weight loss. And as soon as you stop the therapy, if you are not following the lifestyle modification aspect, you will regain the weight. So this is not a substitute to lifestyle modification, it is in addition to lifestyle modification.
Okay, great. Thank you.
Sorry, Mansi. Just a question about that, sir, because I know the Ozempic is not available, but semaglutide oral tablets are available,
Right,
and
right.
we see it a lot in our patients who who already have depression or anxiety, or our patients with all on medications with obesity and
Right.
advised to go on the semaglutide. Is there any data about any worsening of psychiatric issues on patients on semaglutide or contributing to any psychiatric issues?
So Ribelsus is the name of the oral semaglutide molecule. It is definitely available in our country, but again, it is only approved for diabetic obese patients. It is not approved for non-diabetic patients who are just obese. But there is a lot of misuse, as you quite correctly said. Patients tend to procure these drugs just for treating obesity. The psychological issues that might arise out of the use of Ribelsus are mainly related to the GI side effects. Some patients who are using Ribelsus might develop nausea, vomiting, anorexia, and this can trigger some psychiatric conditions or psychiatric symptoms. Otherwise, Ribelsus will reduce the appetite by acting at the CNS level. This should not cause any major psychiatric issues. There have been no major psychiatric comorbidities that have been found in research trials where Ribelsus has been used for treatment. So per se, it should not cause any psychiatric problems. However, misuse should be checked, especially in non-diabetic patients.
Okay, Cheryl ma'am, I hope that answers your question. The next one is, would you recommend treating patients with subclinical hypothyroidism with replacement, especially if they have depressive symptoms? As an endocrinologist, what would you say?
Yeah. So, whenever a patient has subclinical hypothyroidism with depression, so
Yeah.
the guidelines suggest that you should treat those patients with a low dose of thyroxine and see whether the symptoms improve with thyroxine. If there is a definite improvement seen in the depressive symptoms or the depression score, then you should continue the treatment. One thing I would like to add over here is that you should always check the anti-TPO antibody levels in patients with subclinical hypothyroidism, even if they do not have depressive symptoms, because patients where the anti-TPO levels are high uh, should receive treatment irrespective of other symptoms, as they are likely to develop overt hypothyroidism in the long run.
Okay, okay. Thank you. Two or three more questions. Okay with you, or do you want to log off now?
Mansi, may I ask a question?
Sure, please, ma'am. Yeah. But I just wanted to take his permission if he's available. He has some commitments. Dr. Bharat, are you available for a few more minutes?
No problem.
Okay. Darpan ma'am, please go ahead.
Okay, thank you, Dr. Bharat Sharma. It's a very excellent presentation. And thank you, Cheryl, for great sharing and great session by Mansi. I just want to ask two, three relevant questions from practice point. When we prescribe antipsychotics, and sometimes there may be concerns of drug-induced metabolic derangements. So if there is hyperglycemia, so would you recommend the treatment with the mm, OHA or treat it as on the spectrum of pre-diabetes or diabetes mellitus, or you as endocrinologist, you all prefer that it could be drug-induced hyperglycemia? And is there any guidelines that some of them could be reversible drug-induced hyperglycemia? So how would be your approach, that how should we as psychiatrists and collaborate with you as endocrinologist that in this domain of a metabolic syndrome?
Right. So there are certain drugs like olanzapine and certain other antipsychotics which are commonly associated with obesity and development of diabetes mellitus. So it is entirely up to you whether the patient needs that treatment. So if the patient is absolutely requiring those drugs, then I cannot obviously intervene. The patient can continue to take those drugs. And if there is hyperglycemia or obesity, we will manage accordingly. The patient needs to be on therapy for hyperglycemia, if even if it is drug induced, because most of the times the obesity does not go away completely once the antipsychotic drugs are stopped, and once the patient develops obesity, there is a high likelihood of the patient developing diabetes also. So as long as the patient is on those antipsychotic therapies which are causing worsening of the metabolic condition, they also need to be on treatment for either obesity or diabetes. And we have observed that treatment for obesity does not work quite well in patients who are on antidepressants or antipsychotics. It could be due to the interaction of the antidepressant or the antipsychotic drugs with the metabolic condition of the patient, or it could be due to a generalized reduction in physical activity, less drive to lose weight. So definitely there is resistance towards weight loss in patients who are already on these therapies. But uh, just because the condition is drug induced does not mean that we continue to delay the treatment. Even if there is pre-diabetes, now there is option of giving SGLT2 inhibitors and metformin even in pre-diabetic patients to help with weight loss, and at the same time also afford the additional cardiac and renal benefit seen with these drugs.
Thank you very much. One more practically relevant question is in patients of diabetes mellitus who have been we have seen that when they have been recently diagnosed or they have been started on treatment from the endocrinologist or the physicians, and sometimes patients can experience something which looks like a panic or which looks like low mood, but then it can sometimes happens nocturnally or related to their meals. So how do we as psychiatrists understand what is a hypoglycemic or a hyperglycemic episode which looks like a panic or which looks like a mood dysregulation, and should it be treated with benzos or our standard treatment, or we just await for the normalization of the glycemic levels and give some time for their diet and their meal patterns and their sleep patterns to set in? Because in some individuals we understand that nocturnally there can be some free fall, and then the increase or decrease in glucose can affect the hits the brain. So some patients can experience some different kind of symptoms which may look like a panic attack, but sometimes it can just be a hypoglycemia. So can you give us some guidance in your expertise how to delineate these interface areas? Thank you.
So hypoglycemia needs a trial to be confirmed. The patient should have symptoms of hypoglycemia. The blood glucose levels at that time should be below 70 milligram per deciliter, and the symptoms should recover on ingestion of carbohydrates. So if the condition has occurred overnight, there is no monitoring of the blood glucose value. We don't have any history regarding correction of the symptoms after giving carbohydrates. It is impossible to delineate between a panic attack and a hypoglycemic episode. Only with proper documentation in the form of a blood glucose value, either with a glucometer or in a hospital when the patient is actually admitted, can you confirm whether it was hypoglycemia or not. Hyperglycemia will not usually result in panic symptoms, panic attacks. It usually causes polyuria, nocturia, weight loss. Sometimes very high blood glucose levels can cause the patient to lapse into a state of coma, and this usually occurs in elderly patients. It is known as HHS, or hyperglycemic hyperosmotic state, where the patient may develop a coma-like condition. But again, it will not be in the form of a panic attack. So hypoglycemia needs to be documented to actually determine whether it was a hypoglycemic episode or panic attack.
Sir,
I think
one
I
comment. So
the
one last clinical question for you, your esteemed endocrinologist. So in patients of hypothyroidism, when we know that the patient is maintained of 50 microgram of althroxin or 75 microgram of althroxin, and they do sometimes come with symptoms which may have some mood or anxiety. So in those cases, do you think as endo, just a 25 microgram increase of thyroxine will help correct that temporary anxiety or depression, or you feel that our pharmacotherapy increase can help in these interface conditions?
As long as the TSH is normal, we do not make any alterations in thyroxine dosages, just based on the symptoms of the patient. So if the patient is having psychiatric manifestations despite having a normal TSH, then I always refer the patient to a psychiatrist.
That we have really exceeded Dr. Bharat's hospitality. I know this is a very, very important topic, and I think 1 hour is not enough. I think all of us at IPS now will probably, probably organize a day-long CME, because we have so many queries, and like I spoke right in the beginning, it's such a collaborative thing that we see on a daily basis. Dr. Bharat Sharma had another commitment and he was supposed to leave in 30 minutes, but I'm so grateful that you sacrifice more time for us, and I know that you need to leave. So on behalf of everybody, a very, very sincere, heartfelt gratitude to you. And I hope that we can hear you more. And if you have